name is Hugh Reese. I'm a semi-retired orthopedic surgeon. I live in Kelowna in British Columbia, Canada, on the traditional homeland of the Okanagan and Syilx people. It's my pleasure to bring you this webinar on behalf of the Canadian Orthopedic Association Global Surgery. COAGs would like to provide you with an opportunity to look at the practice of orthopedic surgery beyond the borders of Canada and North America. We feel that now, possibly more than ever, it's necessary for us to look at the way orthopedic surgery is practiced across the globe. We feel that this can help us understand each other, as well as trade ideas and forge connections that will make us all stronger. This is the second webinar in a lecture series in which all our presenters practice orthopedic surgery outside North America. Our first webinar in this series featured speakers from low and middle income countries with Dr. Peter Lee Philippe from Haiti, Dr. Nick Ware Omolo from Kenya, and Dr. Robert Hind Tandi from Uganda. In this webinar, we're flipping the script and we're going in a different direction. Both of our speakers today practice orthopedic surgery in well-resourced environments. We believe that this will provide a really interesting and compelling contrast for you. I'm really excited about what I feel is another groundbreaking webinar. The major challenge that we have in bringing you this type of live webinar is, of course, due to the many time zones involved, not only across Canada, but now across the world. And this creates technical challenges and has resulted in another first for a COAGS webinar, and that's one that's presented on a Saturday. So I'm very grateful that you're able to attend today and that Mary Smith, Rebecca Constant, Cynthia Vizina at the COA spent a significant amount of time organizing this event, but also that Mary and Cynthia saw enough value in this webinar that they're willing to give up some of their precious weekend time to keep things rolling for us today. So if you're in Canada, it's morning, and please sit back, relax, maybe pour yourself a cup of coffee and enjoy a look at orthopedic surgery as it is practiced in Germany and the UK. Our first presenter is Dr. Rainer Meffert, who is an orthopedic trauma surgeon in Würzburg, Germany. Rainer will tell you about a normal day in a German level 1 trauma center. We'll have some time for discussion after that. Then our second presenter is Dr. Hui-Ling Kerr, an orthopedic trauma and spine surgeon in Gloucester, United Kingdom. Ling will tell you about a normal day as a spine surgeon in Gloucester. After that, we'll have some time for discussion. And our plan is to record and post this webinar on the COA COAGS website and COAGS social media for future reference. Rainer will be speaking first, so I'll introduce him now. I don't believe I can pronounce his name with the proper German inflection as my wife does so smoothly and easily, but I will do my best. Rainer is chairman of the Department of Trauma, Hand, Plastic, and Reconstructive Surgery in an academic center in Würzburg, Germany, and coincidentally is also my brother-in-law and an all-around great guy. My informal conversations with Rainer about how orthopedic surgery is practiced in Germany were to a great extent what prompted me to ask him to share his stories with my Canadian colleagues in this webinar. He will acquaint you with a normal day in a German level 1 trauma center. So thank you so much, Rainer. Carry on.
Thank you. It's a great invitation, and it's a great honor for me to share some of my work, maybe the daily work I have in the trauma center in Würzburg. Now, maybe first of all, you might be wondered that I'm trained as a general surgeon. 6 years. I did a specialization in trauma surgery for another 3 years. And in my education, I have also a micro and hand surgical specialty. So Maybe just to mention, I don't see a conflict of interest, but I'm a board member of the non-profit organization of the IBRA, and I'm a member of an international developer team, but I don't think we will discuss about any of these implants I co-designed. Well, where are we? I'm not sure whether you all know how to fly over to Europe, and here is little Germany, quite in the middle of Europe. And if you come down, you land on the roof of our hospital. So please make sure, if you want to visit me, not to use the helicopter. It comes about nearly 1,000 times per year with a partially heavily injured patient. And I want to show you a little bit more in the next slides. So my daily work includes clinical, and I would guess it's 80% of that work, teaching, research, and faculty university work also. Actually, it's more than 100% because I have a lot of overlapping there. The day starts with my wake-up call at 5:30, but to be honest, the real life starts at 7 because then we're going to see the patients on the ward before I have a cup of coffee in my office and check on the admissions and the patients to be operated on that day. After the morning meeting with a report of what happened the last night on call starts here, and about 8 o'clock, we're going to start in function. In different functions we have 3 operation theaters, 2 outpatient clinics, emergency room, and of course we have to discharge the patients on the ward. So at 3:30 p.m., we have the afternoon meeting. We discuss all patients of the same day being operated on, and of course the next day. And this gives us a little bit time frame for teaching. So we have our students and the younger residents with us, and we can discuss. For the most younger surgeons, the residents, 4 to 5 p.m. is end of working hours. For me, it's often longer because the faculty work and meetings and also research discussions and documentation keeps the day sometimes a little longish. Now we are 26 medical doctors in the team. You should be aware that 8 of them are plastic surgeons. That's me. That's my first trauma surgeon. That's the chief of plastic surgery. And the rest is a mixture of staff surgeons and residents. And if we distinguish the 2 disciplines, the hand and microsurgery, which is done also by the plastic surgeons of the team, you see some people like me and my first surgeon coping for both. So we both have the training for hand and microsurgery as well as general trauma. And these are the people being in charge, pretty young. He's the shoulder guy, he's the spine guy. These 2 are all rounders. She's heavily involved in the emergency department, sports and knee, and another spine surgeon of our team. And here we have plastic surgeons, and we actually do up to 50 free flaps for our patients per year. Some numbers here from maybe to see how big the department is. We have 60 beds overall, 8 of them for acute admissions. We have about 15 operations daily in 3 operation theaters. We have daily 2 separate outpatient clinics with around about 100 patients. And the emergency in the shock room, as I said, is twice or 3 times a day that a patient is on admission. But we have a lot of good support and help. We have a very high degree of digitalization with speech mic. That's actually my telephone, and it's my private telephone. So I have a simple, easy connection, very fast, actually, wherever I am. So if I would be with you in Canada, I could also manage to see, and I could have a look how the laboratory results are. I can have a look how my x-rays are. So this is really perfect. What's the typical situation? We have quite some high velocity trauma. And what you can see here is, well, the motorcycle drivers are at risk, and the helicopter can land virtually everywhere. So that's what we said. We want to have a circle of 30 to 40 minutes flight by helicopter. We can cope with adequate time for resuscitation. And if you have a look on the Trauma Network annual report of last and the year before, you see our hospital in Germany here. So we have a total of 600 hospitals who have a surgical department. And as you can see here, among the 6 or here 8 hospitals with the highest caseload, we are among the 5% of German trauma centers. So it's quite a bit, with 220 to 240 polytrauma patients with an injury severity score of more than 16. What's our concept? Well, okay, maybe we like Ferrari, but this picture shows something else. Time. We have to be fast. So this is the advanced trauma life support-based damage control. So they're not arguing whether they take off the wheel. That's what their job is, and the next wheel comes here. So no discussion, clear occupation, be fast, because it is very important to find out what the critical injury is. And this shows our double shock room, which is quite unique in Germany. We have built it in 2018, so it's already in the years. But what you can see here is a CT scan, a carbon bed for 2 patients at the same time, and that can be easily coped. So if we have patients from an accident and coming simultaneously, 4 of them, we can pretty much identify the most critical patients, and they go within 2 minutes. We have the CT scan. One group is looking at these, and the next group is looking at that. That's not at night. That's at daytime. This is how it looks like. We have a mobile gantry. So the CT scan goes on this and on that side, and we have more or less simultaneously both patients under control. Yeah, and the next morning when I do the ward round, I'm not on call anymore. I'm 61. So they said, this guy is maybe too old. But nevertheless, we have to make critical decisions. So next morning, ICU ward round, we see a patient with an open contaminated wound here and a compartment syndrome, and really critical and difficult to treat patients, fractures, sorry. We go the simple way. We follow the damage control concept, and what you can see here is the transfixation, the washout of the wounds, the vacuum seal to really get the contaminated as small as possible. And you see combination injuries as it's been shown here, intra-articular distal femur, and tibial head. And this is how it looked like after the treatment, and this is the next step. So we sometimes decide not to do everything in one go. These sometimes are 6 to 7 hours operation time, and we feel that the patient is already injured so much, so we go step by step. We have individual solutions. As you can see here, we use the Vancouver classification. Here you can see a B2, so it's torn out. Unfortunately, the distal shaft is also fractured, and the question comes up what to do first. Plate here, long shaft prosthesis here. So a lot of individual decisions have to be made. Well, here, very distal lower leg fracture, 3rd-degree open. You see the rest of a free flap, and you see the nail in both directions. And if you have a look at the proximal part, we had the combination of shaft and metaphyseal tibial head fracture, and these are, well, quite individual solutions. You can't find them really in the textbook. High energy wrist injuries we do see quite frequently, sometimes as bad as this one here. And it is, of course, just the hand. There was a femoral fracture and other things too. But what can you do with that? Do you need to do anything? Well, we do the following. We wash out the wound, we decompress the nerve, and use again damage control concepts for this complex injury. And then it gets a CT scan before we step in, and you see here, we're not sure what is it, but you can see that's the cartilage from the radius for the radiocarpal joint. And once you have understand the injury, you might fix it, and 5 years later, you are maybe happy not to experience osteoarthritis, too much of those. And if you imagine you come from here, that's quite unacceptable result. We have about 100 pelvic ring fractures per year. This is a bad one. This shows a transforaminal fracture, dislocation of the lateral process, double-sided anterior fracture of the pelvic ring. So we try to keep it easy or simple, as good as possible, and sometimes a fixator alone is doing the job. If we have unstable patients, sometimes we have to decide whether we pack to control bleeding or whether we do embolization. I show you later. This was the result. So the fixation between spine and pelvis and the securance of the SI screws. You see the mini plates from the hand tray. This is where we have decompressed the nerves together with a neurosurgeon. We have a very good collaboration with our neurosurgery, which I will show you later with the spine injuries. This is how it looked from the side. This is where the external fixator pins go in. Well, yeah, it goes worse. This is a professional horseback rider, and she fell the heavy horse on her leg, and there was an avascular right leg. So we had to make decision, and we found we have to go there anyway. That's the first thing we did. And finally, we also did the Cocker-Langenbeck approach and the ilioinguinal approach as the first. And again, you see mini plates here for the reconstruction of the posterior wall. This is one of the ugliest I remember. So this is a very unstable and bad injury to the pelvis, also, of course, to the acetabulum. And as you can see here, also a femoral neck fracture. And we finally acutely had to embolize here, do an embolization. And here you see the primary reconstruction over using a total endoprosthesis. This is rare, but it happens, and we have to be prepared for that. Spinal injuries, we will hear about this much more in the next talk, but we also have these patients, and we know how bad that is. And this is the close acute management between trauma surgery and neurosurgery. So we usually do the exploration, do the reposition, do the stabilization, but everything that goes with decompression of spine or roots is taken over by the neurosurgeon. So we very often stand shoulder to fix these bad injuries. It's more than 10 years ago now that we completely switched, whenever possible, to a percutaneous technique to fix the spine. Of course, we have injuries like this with a C-type torsional injury where you have to have a long exploration. But we learned also that smaller approaches are with a very high precision in percutaneous technique. We have published that in the European Spine on the first 500 percutaneous screw fixations we have done and had a good result. We see here cages. We use the thoracoscopic approach for the anterior column, as you can see here, and that includes also the cervical spine. Now, if you look what the high velocity spine injury went down, but the hyperextension fracture, which is kind of ugly, with the elderly patient, rose very much. Concerning teaching, we try to do problem orientated. So what I said about taking care of the patient, clinical work, and teaching often goes together. So I have 1, 2, 3 students with me, and we looked at the picture, and if they're fit and fine, they say, well, I guess it's a Monteggia. That's right, but they don't know that this diagnosis from Monteggia was done 100 years prior to the X-ray from Röntgen. So there were good classifications here, but just the recent one I want to show you that we also want to include the recent results like this one here. We always do a CT scan in complex injuries like that. Why not using a CT-based classification? And that's rather new. And we try to implement to put it into our teaching. And it goes teaching step by step. How to put the patient prone position, tourniquet, what is an anconeus flap? You can see that here. And you can clearly see the X-ray and the clinical situation, so they can really learn that. So how to proceed? First of all, you have to find that piece of the radial head, you fix it, you push it back into the length, and then you close the ulna, the proximal ulnar fracture, whatever implant you prefer, double plate, dorsal plate, there are different things. But this is also of interest for our students. We recently have joined, or we have the Loose Fit Evolve prosthesis from Graham King. Everybody of you in Canada should know him. He has done excellent biomechanical investigations around the elbow. And following these concepts, we have his prosthesis now. If we need a longer prosthesis because of fracture around the neck, we have a modular model to do that. So finally, the last 20 years, and that's the time I overlooked my position here, we did 24 hours, 7 days a week, every day, a year. And this is just possible with an enormous input of all of our doctors, co-workers, sisters. It's a team approach. And I'm pretty happy to look back to that time and to see that we never had to close our doors for emergency cases. So I found that you has problem with Würzburg. And so I'm going to show you a little bit. This one is 200 years old, the residence, wonderful garden. That's the view down to the little city. We have at least 150,000 inhabitants. And this is a castle that's 1,000 years old. And this one is the place where I work, and it's 25 years old. So hopefully you take as a main message that in Bavaria is more than just big beers, Lederhosen, and Oktoberfest. And as you can see, I took a Bavarian shirt today to represent my country. And this is my disclosure if you want to have a closer look. And I hope I'm not too long here.
Thank you so much, Rina. That was really an excellent talk, and I think underlines the fact that when we don't talk to each other, when we don't have the opportunity to speak with orthopedic surgeons outside Canada or the US, we miss opportunities to think about things and to consider what we can use and translate into practice in Canada. So I find that I don't know. I find it fascinating and useful and helpful in so many respects. And is there anybody that would like to ask Rina any questions now? We'll have another opportunity at the end, but if you're welcome to ask questions. If not, I have one quick one, but go ahead. I'll open it up. All right. I don't see any hands up. Do you, Mary? Okay, perfect. We'll
Nothing
we'll
yet.
carry it. Sorry.
Sorry, nothing yet.
Okay, good. Perfect. Okay. So Ryan, I guess the one question I have for you is, do you see any opportunities potentially for collaboration between Germany and the UK, or your center or other centers in Germany and the UK? And that is whether it is with respect to fellowships and collaboration, academic collaboration, or research, or anything like that. Is there something, do you collaborate with other countries right now? And do you see any possibilities in the future for collaborating with Canadian surgeons or Canadian institutions, other than Graham King, which you're clearly collaborating with already?
Yeah, one of my senior surgeons visited him for 6 weeks and wanted to see him firsthand how he is doing that. And he was so convinced, so we took the new prosthesis, which works really nice. But yeah, um, this way it's maybe easier. But one thing I would like to pronounce is don't worry about the language. Most of the medical doctors speak better than I do. So we have guests from abroad, and English language is in the operation theater, maybe not with all patients, but you're not alone with patients when you come over and do a hospitation here. Um, Funding is a theme, whether these doctors, these young doctors, receive funding from their home country or whether we find, and there are options to get funding from them. If you want to be on a resident position and want to stay all the 6 years of total training, then you need to have German. Um, I think for that, it's necessary.
Fair enough. Okay.
Collaboration, I think on a student level, immediately, I don't see a problem. On the residence, more hospitation than staying for years. I think that's also more the idea. And yeah, and research, yes, fine. I don't have it with Canada now, but I work together with people from Australia, Great Britain, Switzerland. So we have projects we have together. And people from Canada are more than welcome.
That is excellent. And yeah, that's really good. I hope we have the opportunity to talk to you again sometime in the future about some collaborative effort. So, yeah, thank you so much. I really appreciate it. We will move on to our next presenter. Thanks, Raina. That was just great.
Thanks a
Our
lot.
our next presentation is from Dr. Hui-Ling Kerr, or Miss Hui-Ling Kerr, as she'd be addressed in the British system. Miss Kerr is a trauma and orthopedic spine consultant who practices in Gloucester in the United Kingdom. Somehow I have a hard time saying Würzburg, but I can say Gloucester, okay. We were introduced by Supriya Singh, who is the beloved outgoing COAG's chair and a London, Ontario spine surgeon. When Ling and I had the opportunity to discuss the plan for this webinar, like Raina, Ling understood the premise of the webinar, was all in, and generously agreed to speak to us today. I know you'll enjoy hearing a normal day as a spine surgeon in Gloucester. So thanks very much, Ling.
Thank you, Hugh, for that kind introduction. And thank you also to Raina for your wonderful talk. I really did enjoy it very much. I'm Hui-Ling Kerr. I'm an orthopedic spine surgeon working in Gloucester. And for those of you, oh, 1 second. Let me just click. Firstly, I've got no disclosures to mention. So for those of you who don't know me, I do have a connection to Canada, as Hugh said. I was a fellow back in 2018 in London, Ontario, and had a wonderful year there where I did get to experience the joys of Canadian winter. There's a picture of freezing rain that made the trees look so beautiful. And I had to go to work every day in minus 35-degree weather, dressed up like I was going on an expedition to the Arctic. But it was a wonderful year. And through that experience, I met the beautiful person who is Supriya Singh, and we've become friends and have stayed friends all these years. So thank you also to Supriya for inviting me to talk today. So where's Gloucester, you might ask? Well, it's there in the southern part of England. We're actually right on the Welsh border. And in our catchment area includes Cheltenham, and we extend as far down as Bristol and to the edge of Worcester and Hereford as well. What's Gloucester famous for? Well, we're actually famous for a competition called the cheese rolling competition, where some of you might have heard of this. A massive wheel of cheese is thrown down a steep hill, and international guests come from all over the world to chase this thing. And in the process, some really horrible injuries can occur. And most of us do try, if we can, not to be on call that day when the cheese rolling happens. But that's something we are famous for. And in our sister city, Cheltenham, there is the Cheltenham Races, and that's quite famous for being a rather posh event, particularly the Gold Cup, where the Queen and other royals attend, but also some traumatic injuries can occur as well. Usually the jockeys who suffer clavicle fractures and or upper limb injuries usually, but anything can happen. And that can include the regular people that come to the event that usually get quite inebriated after the event and can suffer drunken injuries as well. So that's my hospital, Gloucester Royal Hospital. We're a large district general hospital, so not quite the same volume in terms of trauma as a level 1 trauma hospital that Rayner works in, but we still serve a large population of close to 700,000 people, and increasingly the number of patients we get are elderly over the age of 65. We also take part in teaching and training as well. And the large tower block that you can see in the bottom right-hand corner of the screen is the tower where I and the rest of the orthopedic surgeons do our work. So the history of Gloucester goes back a long way. And most recently in 2004, we did merge with Cheltenham Hospital to become one large trust. And as this slide suggests, we serve a population of close to 700,000 people, close to 700 inpatient beds, and almost even close to 1 million outpatient visits a year, 150,000 A&E attendances a year. So we're one of the biggest and most busy trusts in the country. So what's my typical day like? Well, it actually does depend on the day. Along with my colleagues, I have a share of the orthopedic on call, which is quite rare for a spine surgeon. You'll find many spine surgeons, not just in the UK, but in Canada as well, just do purely spine. But in our department, we work together with our general orthopedic colleagues, and there are about 30 of us orthopedic consultants, but not everyone's on the on-call rota. So I do share that with 23 others. And there's 6 of us spine surgeons. So we also do a spine on call Monday to Friday during working hours. Outside of working hours, the on-call is devoted to Bristol, where the level 1 trauma centre is. I do elective spine clinics and theatres, and I also do trauma spine clinics and theatres as well. And I have a private day about once a week. So that's what my timetable looks like every month. So what do I do week to week changes depending on what week it is in the month. But in general, it's a share of, as I said, clinics, theatres. The most consistent day is Thursday, where I have private work. And I do a few days are given to admin and also trauma theatre as well. So a bit like what Rayner was explaining, the day's very similar. My alarm goes off at 5:45, and I've got about half an hour to get myself washed and ready with my coffee in my hand. And at home, I actually open my computer with my partner next to me, still sleeping, while I look at the admitted cases from the night before. Because I do spine on call as well as orthopedic on call, the number of on-call days seem to be never ending and coming very, very soon with each other. After I've looked at the cases to decide what needs to go to theatre that morning, I get to work for about 7:30 in the morning. And then we have our trauma meeting. I go to speak to the trauma coordinators, start the trauma meeting at 7:45. And then I don't have clinical duties in the form of theatre or clinics. But when I'm on call for orthopedics, I'm purely there to see the on-call patients. So these days, the post-take ward round will take me to close 12 o'clock because of the volume of patients. And then in the afternoon, I have to see the ward patients as well. And I'm responsible for them, along with the junior doctors on the ward, where I'm really doing a board round, checking who's unwell, who needs to be seen, and guiding them. Then in the afternoon, we have a system called trauma triage, where all of the patients that I've seen are mainly walking wounded for the surrounding A&Es and minor injury units around the county are sent to us in a referral system. And I literally have to go through them one by one, looking at the x-rays and deciding which clinic they should go to. And I have to write on the computer how soon they should be seen, which clinic they should be seen, or if they should be seen at all. So you can tell by the end of the day, having done hundreds and hundreds of decision making and solving and problem solving, that's a picture of what it's not me in the picture, but that's how I feel like at the end of the day. When I'm spine on call, it's something similar. I still have to get up early and check the computer, but normally when I'm spine on call, I have to do my normal elective duties. So I'd get to work for 7:30 to consent the patients if I'm operating, or requesting x-rays in clinic at the time. I still try to go to the trauma meeting to support my on-call orthopedic colleague, and then I have to run to theatre or clinic to do those activities, and I finish the working day usually around 7 p.m. as well. The orthopedic on-calls are split up in our department from Monday to Friday in a block, or you're doing Friday to Monday. So I've just done Monday to Friday this week. And then we also have a share of weekend trauma operating. So we'll have Saturday and Sunday operating to do. And on those days, it'll be a mixture of spine cases and or orthopedic cases. And then I also do a night on call, and every surgeon has their own weeknight they're given for a night on call, and mine's usually Wednesday night. As I said, my spine on calls are usually only workday, so Monday to Friday, workday hours, 8 a.m. to about 7 p.m. And overnight and weekends are covered by Bristol. But generally, most patients who are referred to Bristol overnight, they simply say, just manage the next day. And so we would pick them up in the morning. Of course, there's the occasional cord compression or cord Aquinas syndrome that they would accept. These are exactly 2 patients that we had during this week of on-call. And when I'm on call for orthopedics, I'll be managing the spine patients as well, even though there'll be a spine on-call person alongside me. So I will cover both when I'm on call for orthopedics. So here's some photographs of my colleagues. On the left are some of my nursing colleagues. This is the spine bit on Ward 2A. We've got our own spine annex where we have 8 beds. And in this 8-bedded unit, we've got a small nursing team dedicated to the patients. Here are a couple of my patients on the right who day 1 post-op, and I'm glad they're looking nice and jolly for the picture. Very pleased with their surgery, and that's one of my registrar colleague that was with me that day. And these are some of the corridors on the way to theatre, and this is in the middle picture shows my colleagues waiting to go into theatre. And on the right, there is a clock showing it's about 5 to 9 a.m. Hopefully you guys can all see that. And it just shows, unlike my experience when I was in Canada, how patients would be on the table by 8:45. Sadly, for our hospital, it's not as efficient. We've had a problem with CSSD recently, and kit coming up, unfortunately, not clean or not sterile enough. And therefore, we've now got a policy that all the kit has to be checked before patients put to sleep. And that does put a delay on our start time, which is frustrating for everyone. That's our little room where things are stored before you get into theatres. This is for the spine theatre, Theatre 12. And in Theatre 12, that's what it looks like, which is pretty much a standard room like most operating theatres you have in other public hospitals. And that's our scrub room there, pretty similar to what people would have in either Germany or Canada, I would believe. And that's an example of the theatre staff I was working with that day. So the nursing staff, the anaesthetist, and some other colleagues, including the radiographer. That's my office there, a bit messy, but that's where I sit and do my admin work. And I share this office with my 4 other spine consultant colleagues and the secretary. And just to give you an example, what it's like on an elective day when I'm not on call, still the wake up time is 5:45. I still check the computer in the morning. I still have to go to consent the patients, operate, or go to do clinics. And for my clinics, I do peripheral clinics too. So Stroud is about 45 minutes drive away. Cheltenham's 30 minutes drive away. Thankfully for Gloucester Royal, I can cycle to work in 5 or 10 minutes, which is a blessing. And then clinic is full on. It runs in the morning from 8 a.m. to 1 p.m. and then 1:30 to 6 p.m. So there's about 30-minute break for lunch. And generally for spine patients, you have about 20 to 30 minutes for a new patient and 15 minutes for follow-up. But obviously there are patients that require more time than that. And it's very often that I'm eating over into my lunch hour or lunch 30 minutes, and I have to run late and only have 5 or 10 minutes to eat something quickly before carrying on with the afternoon. There are extra duties. I'm an educational supervisor for a couple of first-year doctors and a registrar. That's equivalent to the residents in Canada. And that means I've got to find extra time to support them. That usually means after clinic between 5 and 7 p.m. I'm meeting up with them to talk about their educational needs and any issues they might be having during their training and filling out their training reports. In addition, I'm the mortality and morbidity meeting lead for our department, and I organise 2 to 3 meetings per year where we discuss all the cases where sadly the patients came to harm or died, where we can learn from any mistakes or problems that we had in the system. I'll mention my private work. As I said, I do 1 day a week. When I was in Canada, what I found fascinating is that nobody in London, Ontario did any private work, and I was told it was considered not fair and it was a government directive so that patients couldn't skip the queue and have their surgeries done privately. And a lot of patients were flying to America to get their surgeries done. In the UK, the private system works alongside the public system. And as a consequence, my Canadian colleagues were very, very curious about private work and what it was like. And so I'll sort of answer some questions here to what people might be curious about in terms of pay and the function, so forth. So in the NHS, the starting salary for consultants is about £96,000 a year, and it goes up incrementally to about £120,000 a year gross. But in the UK, once you earn over £100,000 a year, you're a higher rate taxpayer, which means you're paying about 40 to 45% income tax, and you lose a tax-free allowance. So effectively, one can be feeling that, your pay packet feels quite small, regardless of how much you earned. And we don't have any extra pay for the evening or weekend work. So there's a big push from all the nurses, as well as anaesthetists, to finish exactly on the dot at 5 o'clock. And the take-home pay, is about £5,000 to £6,000 a month after the tax has been taken out, which sounds like a lot when you're a trainee, but actually once you're a working consultant with family and mortgage and so forth, it doesn't seem to stretch that far. In the private world, you get to charge per patient encounter. So if you are seeing people in clinic, you can charge a few £100s for a new consultation for a self-pay patient and less for follow-up. And you can charge what you like really as a spine surgeon in terms of your surgeon's fee, which is usually comparable to your colleagues, depending on the type of operation and the complexity. Of course, if the patients are coming from an insurance, having paid for their consultations, you don't get paid as much per encounter. And again, what you get paid for the operation is less. In the private healthcare system, you can also see NHS patients, and that's called choose and book. And in the choose and book system, they're just NHS patients who've been waiting too long to be seen in the elective service through the NHS hospital. So the GPs offer the contracts out to the private hospitals. And so in our hospital, I'd get paid £75 for a new 30-minute appointment, £25 for follow-up. And of course, once you minus the tax, it's only £12.50 to get to see someone for follow-up. It really doesn't feel very much remuneration for the amount of time you might spend with the patient for follow-up. And then, of course, the operation, the payment for the operation is much less. But all in all, if you do private work, you can earn into that system, in an average month, maybe £5,000 up to maybe £15,000 a month, which is pre-tax. But in the UK, of course, nothing escapes the tax man, and that's where some of the woes from doing private work comes in. Firstly, depends on the structure of how you do your private work. If you run yourself as a limited company, you pay less tax, which is corporation tax. But still, after the corporation tax is paid, if you want to take any money out, you'll still be subject to pay the 50% income tax on top, whatever money you take out of your limited company to spend on yourself. And of course, if you run yourself as a sole trader, which is another system, you still pay corporation tax, but then the government's brought this thing in, which is called Making Tax Digital, where you have to do quarterly returns, which if you add that on top of all of your other administration problems, becomes quite a big headache. On top of that, as a private surgeon, you'll have to pay fees to the hospital, your secretary, and the medical indemnity can be very expensive. Starting the first year, you might be paying £3,500, and every year it goes up exponentially, doubling and then quadrupling or tripling or quadrupling for subsequent years. I have no colleagues who pay £30,000 or £40,000 a year, and then you've got to think to yourself, you've got to earn £30,000 to pay off that fee per year before you're actually earning any money for yourself. And then you start to question, well, how much work do you have to do in order to get that amount? And of course, you have to do your own accounts, and that takes up time that we all are short of. And when you've got a private patient, they actually do become your responsibility, and that's day and night. And you can found yourself being rung by the nurses, by the patients, day and night when you're trying to rest or go on holiday, which can be quite stressful. Of course, being a surgeon doesn't mean you just do your clinical work. And teaching, you have to do other interests and leadership activities too. And for a few years, I was involved with the British Association of Spine Surgeons, where I was a diversity rep for a couple of years and membership rep for a couple of years. And I used to have to attend these evening meetings once every 2 months. As you can see, they're all men. And I've been one of my goals for being in BAS was also trying to bring up the idea of women in spine surgery. And I've been trying to talk about this issue since 2017, since there's so few of us in the community. Back when I was a trainee, this was the status quo. You go to a meeting and it'd be really a sea of men with no friendly female faces, and it would feel quite isolating and quite intimidating as a trainee. And I'm pleased to say that with joining of BAS and highlighting it, and trying to start the project of the Women in Spine Education meeting, we've managed to have 4 successful meetings over the last few years, bringing really female trainees, consultants, working in the field together of all faces and creeds. And we've really had some men join us as well in the last year, which is really great. And it's a wonderful day and a half conference we have in November every year. And I'm very pleased to be part of this community. Other things we've been able to do for the Women in Spine Initiative is present to the things like the BOA Congress with an all-female panel. This was in 2023, and the same most recently in Aberdeen for the British Association of Spine Surgeons annual meeting. In Gloucester, I have an interest in teaching, and with my colleagues, we set up the Gloucester Basic Spine Principles course, which we've run for the last 3 years, and we've got another one this year as well. And it came about because a senior colleague of mine had a junior doctor say, well, there's no teaching courses on spine for people below fellow status. So he suggested, well, why don't you start one? I thought that was a wonderful idea. So that's what we've done for the last 3 years. We've done with the aid of my colleagues and some very kind sponsors. And it's a great day out where we have practical skills teaching as well as hands-on sawbone teaching and lectures. I thought I'd talk a little bit about more training as a consultant, because as a surgeon, really, your learning should never stop. And being an orthopedic surgeon is a wonderful thing, because you can also always follow your dreams and travel. So given this webinars about global spine surgery, I thought I'd talk about my time in South Korea, where I had an opportunity to spend 2 months there back at the end of 2024. So I was in Daejeon, and South Korea, you can see there, sticks out as a peninsula off China, bordered, of course, north by North Korea, and Daejeon's bang in the middle of South Korea. For anyone going to a foreign country to do a fellowship, whether it's a year, half year, or even a few months, even though, yes, usually language is not a problem with the advent of a mobile phone and language apps on your phone, but it is still useful to learn some of the local language. I would encourage everyone. So, for example, when I came for my first day to the hospital, which is the middle picture, the only reason I realized it was hospital is because firstly, there's a picture of the people in white coats outside, and I could just about read the words. It said Daejeon-Wuri Pyongwan, which means Daejeon-Wuri Hospital. And I'd spent about 3 months just doing a bit of Duolingo every day to learn some Korean before I came. And I learned under this guy called Chulun Park, who's a really wonderful professor of neurosurgeon, and he wrote with his co-collaborators the book on endoscopic spine surgery. And that's us in the daily morning meetings. Of course, the meeting's completely in Korean, but you can tell from the imaging what's going on. And he would have other fellows and visiting dignitaries come to his theatres as well. What I find fascinating about going to other people to learn about spine surgery or even the way people do things is that what is normal in one center or one country is maybe completely different in another country. So in his hospital, pretty much all the patients had their spine surgery done under epidural anesthesia, which would last 2 or 3 hours. And they would pretty much did that for everybody. Here we've got the technicians, after the anesthesia is delivered, putting the patient prone in the operating theatre before their legs completely go. And they would also begin sedation, even if they were an elderly person. And the reason why I realized they could do it is because the South Korean population is very slim. So on the right, the pink poster shows a weight loss poster I found when I was cycling around one day. And there, in each of these little photographs, the left-hand one is the one of them being fat, and the one on the right is following the weight loss program. So you can see their standard of what's considered obese is quite different to us in the Western world. And some of it might be due to the diet. I mean, this is a photograph of the restaurant at the bottom of the hospital, and that's what the restaurant in the hospital were selling or advertising what they would sell. And a picture in the bottom right is what we were given as workers to have for lunch every day. Lunch in the hospital was free, and every day was a different meal with usually rice, a number of different pickles, vegetables, and one meat dish and broth. And the meal plan for the entire week would be advertised 1 week in advance every week. And this was a requirement by law in South Korea for all hospitals and schools. And this was mandated and I think a testimony to how the South Koreans are so fit. As a consequence, one of the fellows I was working with, this is Dr. Amit Gurung, who's from India, and he actually lost weight over 1 month of being there. The right-hand picture is him before, a year prior, and the middle picture is him after losing weight. And he was so pleased, and that was simply by eating Korean food every day and taking the bus to work every day. They could achieve a huge number of surgery through endoscopic spine, 36 cases in a day in 4 spine theatres. And that was simply because of the staff, the technicians who would get the patients in and out. And they were really amazing using that Formula 1 approach that Raina described so accurately. As a consequence, through collaboration, I got to meet other surgeons from Taiwan as well. And these people are people I could always call on potentially to go visit their departments and stay friends with them for life. I thought I'd talk also about maybe some primitive examples of healthcare. In 2016, I got a chance to go to Myanmar because it was a friend's wedding. And I'll do this quickly. Myanmar is a country nestled in between India and China. At the time, it was still under democracy. And it was the most amazing country full of beautiful temples and wonderful people. And I got to go there because my friend's mother was one of the chief nurses in this big hospital that was the biggest hospital in Mandalay. And I took some photographs when I was there, and you can see the very primitive nature of their wards with only very frame beds, no hospital bedding. They had to wear their own clothes as well. And I got to meet some of the surgeons, and I even got to see some spine surgery with although they only a couple of trays, their instruments were quite a bit rougher than what we're used to in the Western world, and more and felt more less well machined, but it still worked, much cheaper. And they had to use what they could. So they would, for example, use some of the sterile foil to make light handles of for the surgeries. In theatre, the surgeons had to wear flip-flops rather than regular shoes, although they did have C-arm. And patients would be brought to theatre on a sort of T-trolley type apparatus. And all in all, it was quite a primitive setup. But of course, it's even worse now because of the war. I heard many doctors I'd met had to swap stethoscopes for machine guns and enter the jungle as rebels. And with the big earthquake that happened a few years ago, many of their beautiful temples and pagodas were destroyed. So in summary, I'd like to leave here a picture also of one of my patients. And even though in Gloucester, as I've explained to you, the day is very busy and I'm completely exhausted at the end of it. But the reason why we do this hard work is for the joy of seeing patients get better. And I've just included a picture of my patient here, Maureen, who came to me with myelopathy when I first met her, and she could barely walk, was using a Zimmer frame. And when she'd recovered from her posterior cervicothoracic decompression fusion, she brought a piece of paper with all the things she could do, which we all take it for granted, which include things like washing, cleaning, cooking, even writing and doing up buttons. And so I'd like to end this by saying that even though, work is very busy, no 2 days are the same, but I think taking on the extra roles, that gives us extra presence, gives a great reward. And as an orthopedic surgeon, you'll always have opportunities to travel. If you do want to do overseas fellowships, look out for opportunities and pursue them. And if you're lucky enough to live in a civilized country, there will be free healthcare. And if you're even more privileged, there will be well-run public healthcare systems. And there is definitely a desperate need to defend them and to defend democracy so that we don't fall into a ruinous state as what has happened in Myanmar. Many thanks.
Thank you so much, Ling. That's, I think, really an excellent place to leave it. And with both your talk and Raina's talk, I truly believe there's something for everyone. Everyone must have learned something, and there's a lot to think about. And I mean, even for myself, we certainly have seen a certain amount of horse-related trauma in Saskatoon, but never any cheese rolling injuries. Never even considered it. So there's that. There's also the fact that when I listen to both of you and what you do and your days and how you think about things and how dedicated you are, I will never complain about my life as a simple foot and ankle surgeon in Saskatoon. So thank you very much to both of you. I'd like to open things up for questions if there are any, and then if not, I'm going to ask Ling the same questions that I asked Raina. Anybody have any questions before I do?
Is it okay if I ask a question?
Of course.
What's the collaboration between orthopedic and neurosurgery in the field in your specialty in spine? Do you do collaboration, or is it clear defined what's doing the orthopedics and what's doing the neurosurgeon?
Thank you, Raina. That's a very pertinent question. In the UK, spine surgery comes from two arms, a little bit like hand surgery as well in the UK. So for spine surgeons in the UK, you either train in neurosurgery or train in orthopedics. And generally, when you join a centre, you take on a role that does a bit more of one type of the spine. So, for example, a neurosurgeon in a unit might do more of the intradural work, but usually they're competent enough from their fellowship training to do instruments too. And orthopedic spine surgeons tend to do more of the deformity work and not do so much intradural work. And generally, the skull-based work we leave, and the higher cervical work we leave to the neurosurgeons too. There's some. It depends on the center. So in our center, we only have orthopedic spine surgeons, and that's because in our center, anyone who comes in has to do the orthopedic on call. So we tend to only advertise for orthopedic spine surgeons. But in Bristol, the on call is there are neurosurgeons and orthopedic spine surgeons doing their on-call, and they work together. So
Thank you.
in the UK really depends on the center and what your center is trying to achieve.
All right, thank you. I know, Ling, you have a dinner date to get to, and we're a little bit over time. I'd like to just squeeze in a quick question, please, about just very quickly if you see opportunities for collaboration, and if so, how, and then we'll sign off after that.
Thank you. I think there's always room for collaboration. It partly comes out of seeking and looking for the opportunities, no matter whether you're a registrar, a resident registrar, or consultant. So, for example, how I came to Canada is that one of my bosses, Mike Katsamias, came to London, Ontario to do his fellowship, and I just asked him how he came, and I got that connection. For my time in South Korea, I went on some courses and in endoscopic spine, and I was told if you want to learn more endoscopic spine, try your best to go to South Korea, Taiwan, or China. And I was on the lookout for a connection, and I actually found a connection through one of my registrars when we were doing a neck of femur fracture surgery together, hemiarthroplasty, and he told me about his friend who'd gone to South Korea to learn endoscopic spine. So I think if you, no matter where you're working, if you just talk to people, talk to them about what's in your imagination, what you would like to do one day, and even if you are looking for connection but don't manage to achieve one, there's nothing to stop you from looking someone up or looking up a center or someone working in a country, their hospital, and finding a way to reach out. I think but the only thing that limits us, I think, is our imagination.
Thank you so much. That's great. All right. All that remains is once again to thank you both, and also to thank Mary and Cynthia and Rebecca from the COA for giving us this opportunity. And also to put a very quick plug in for the Canadian Orthopedic Association Global Surgery. If you would like to be involved or would like any more information about COAGs, please go through the COA website to COAGs, and there's contact information there. Also, if you are planning to attend the COA in St. John's, Newfoundland in June of this year, please do attend our COAGs symposium, and also, if you would like, our COAGs think tank. That is all I have. Mary, the closing words can go to you. Thank you so much to everyone.
I would just like to thank our speakers for joining us, and we look forward to the next one.
All right. Thank you so much.
It was a pleasure.
Thank you.
Thank
Nice to
you.
meet all of you. Thank you so much. Take care.
Thank you.
Bye.